Thank you so much for tuning in to the 46th episode of the Psychology Is podcast. I know we have many consistent listeners, so big shout out to you all. And if anyone is here who has never listened to this podcast before, welcome from the bottom of my heart. I'm Nick Fortino. We talk about all kinds of different topics on this podcast, but we've been focusing on an analysis, a critical analysis of modern day psychiatry. And I'll tell you too, for those of you who are tuning in kind of as these episodes come out, that we've done several episodes that focus on this topic, and we have several more in the very near future. It's interesting to observe, what episodes have the most views and listens. And it's so far, it's been the episodes on this topic. So there's clearly a very strong appetite for this type of content, these critical conversations about modern day psychiatry. And I'm here with Dr. Sami Timimi today, who is such an important voice. So thank you so much for joining me, Dr. Timimi.
Well, thank you so much for inviting me, Nick.
You're very welcome. You've been on my radar for some time, but like Dr. Peter Gutsche, for example, explicitly recommended that I reach out to you and speak with you. I think Dr. Joanna Moncrief also gave you mention in my conversation with her. So yeah, and I've been just preparing to talk to you. I read your book, Insane Medicine, which I highly recommend to people. I find myself saying that a lot, but it's true. I wouldn't be interviewing these people if I didn't find their work very valuable. And I find your book, Insane Medicine, to be unique, even among all of the critical examinations of psychiatry, for a couple of reasons. Number one, you're an insider. So like the books, for example, by maybe Robert Whitaker are invaluable, and he's kind of on the outside looking in. He's a journalist. But then people like you and the other two I mentioned, Dr. Gutsche, Dr. Moncrief, you are psychiatrists yourselves, and you in particular are still in practice as a child psychiatrist, and you're based in the UK. And I just think that the insiders' voices are especially powerful. And the other thing I find unique about your book is it's at the same time, I think, the most scathing, the harshest criticism of modern day psychiatry and the dominant ideology, and at the same time, the most optimistic that things are going to change. I mean, you even say the paradigm shift is inevitable. And it's interesting because I think that's connected. I think your piercing insight into the core of the problem is exactly what makes you so confident that things are going to change. And you say, like, whether it's 5, 10, or 50 years, it's hard to say exactly when, but it seems that you have no doubt in your mind that the ideology that dominates modern day psychiatry will be, I don't know what the right word is, right? Like overthrown, left behind. Because it's not like it's going to be transformed or modified. You call for a complete departure from this ideology. So yeah, that's what I find so unique and powerful about your book. And I just appreciate the way you've written it, the way you don't hold back. Can I just ask you in my first question before we really dive into the content of it? How long did it take you to write this book, and what was the experience of writing it like for you?
So I've written and edited several books before, and I guess over the years of writing and critiquing, and I keep going back and looking at the literature and trying to understand it. The position that I lay out in Insane Medicine was something that was sort of slowly coalescing into this being. Interestingly, what happened was I started writing it. I'd been scribbling down in various places the concepts and as they were coming together. And so I had all of these bits and pieces in different places. And then when COVID happened and we were sort of all sent home and started working from home, and I just found myself with time on my hands, and I started putting these different bits and pieces together. And it's one of those things I find writing once, it takes a while you're collecting the thoughts and the ideas, but once you get going, it just sort of, so the actual writing of it probably took place completely in about 6 months. I probably finished it all. And interestingly, I went to some publishers and some agents. But then I decided, because I got some comments back, and they wanted me to write something different, or they wanted me to change this, that. And then I thought, no, I want to write the book that I want to write. And if nobody buys it, if nobody's interested, that's fine. I want to feel free to write what I actually genuinely think, whether it's right or wrong, the conclusions that I've come to. And so I self-published. And actually, it seems to have been received quite well.
Good to hear that. Consider me another, positive recipient of the book. I'd like to read a quote here to kind of break the ice into diving into the content. Right in the beginning of the book, I think it's in the introduction, you wrote, "This book digs through the rotten undergrowth that sits beneath the artificially scented man-made plastic gardens that we call mental health care, and that look and smell so nice on the surface, but release a stench if you poke your head in too far." And then what you do in the book is you lead us to poke our heads in through this, and I know what you mean when you say this kind of, this whole edifice that can smell so nice and look so professional and polished. There's a certain flavor that a person gets, I think, when they just start to look into mental health care services, and they see, oh, okay, so there's this entire book with all kinds of different disorders that we've discovered, and there's, we understand them, and there's ways to treat them, and if you just ask your doctor about this medication, you might be, on the right track again. But I couldn't agree more that there's this disgusting rot beneath that is marked by, monetary incentives from drug companies and just flimsy concepts with no real validity to them, and just downright false narratives that are perpetuating many different cultures. So let's dive into it. And the next question I want to ask you is basically, can you just articulate for our listeners, what is the dominant ideology that you say in your book is the real problem here? The central problem is the dominant ideology. What is this dominant ideology?
Yeah. I mean, that quote, I think, reflects that we've developed an idea and popularized an idea that what we think of when it comes to states of distress or difference, that we can and that we have made scientific advances that has enabled us to accurately categorize these different states into functional categories that are similar to functional categories in the rest of medicine. And so we use the word diagnosis. And that when you get the right diagnosis that matches the condition that you're experiencing, then there are specific treatments that are matched to that diagnosis that have the capacity to improve your well-being. So that's the kind of dominant model. Some people call it the biomedical model because it draws on the idea of diagnosis and it draws on the idea of diseases. But I think it's more than just the biomedical model. I would think of it more as a technical model. So the idea that there are specific techniques that enable you to accurately identify the nature of the problem. And by accurately identifying the nature of the problem, you can identify the correct treatment. And why I think it's probably better to think of it in those terms than just biomedical, because biomedical is dominated by a technical approach, but it's not just a technical approach, is because sometimes people think that when you're critiquing the biomedical model, you're critiquing the dominance, and correctly, the dominance of a pharmacological approach to, to distressed or altered mental states. But for me, the problem is deeper than that, because it's not just the pharmacological approaches, but it's also what we call the psychotherapeutic approaches. If you're fitting them into this same technical model, you're going to come across the same potentially similar issues. It's not the same, but potentially similar issues. But also, when you take that step of categorizing people, that in itself has an effect on the meanings and how you experience the nature of your distress. So it can already have a transformative effect without introducing any therapy, pharmacological or psychological. You've already transformed and given a new system of meaning,
right?
Which then can expand a certain narrative that you start to say about yourself, that other people start to say about you, and that's one of the things that when we're dealing with human distress and behavioral difference, is that how you construct that, the meanings you give that, has a direct effect. And this marks it out as different to other parts of medicine, but not entirely different, because other parts of medicine actually does struggle with the excessive technicalization of the role, sometimes at the expense of the relational and caring side and the meaning side. But just for the sake of understanding the critique, when you're diagnosing somebody with kidney stones, the kidney doesn't get upset about the diagnosis and think, why am I here? Why did this happen to me? So, when you're diagnosing kidney stones, it is a different system of meaning creation as to when you're diagnosing somebody with, for example, depression.
Right.
Because that now has an effect on how you interpret your experience. Instead, if you told somebody they're feeling sad because, they broke up with their boyfriend a few weeks ago, that creates a different meaning system than saying, oh, I think you're suffering with depression. Similarly, if you talked about, you're feeling understandably sad, but I'm really impressed with the way you've managed to keep going and you're still going into school. And, again, the meanings we provide actually have an effect. So we've kind of got the whole thing the wrong way around. We seem to imagine that when it comes to what we're calling mental health, we have the capacity to identify and provide the correct meaning and the correct way of interpreting it. But it's actually the other way around. We're in the business of creating meaning rather than discovering them. And it's the problem gets worse when you imagine that you're actually discovering meanings when in fact you're creating them. And if that lack of acknowledgement of your role in creating meanings, and for you to think that you're actually discovering them by making a diagnosis like depression, aggravates the possibility for people to be able to reinterpret their experiences or have a different frame of reference to interpret their experiences in a way that might help them in the long term.
Right. Your point is very well taken. And I think it's very important because I think what you're saying about how it's one thing to critique the biomedical model, but you're saying we have to take it further than that, because I often mention these key terms that I think are important for people to understand when tracking all of this, which are, the diagnosis, the etiology, the prognosis, and the treatment. And so there are many people, I think there's a greater number of people who are quick to criticize the biomedical model and deny that there are biological causes of these conditions and deny that there should be biologically based treatments for those conditions. And that is a very important critique. And you're saying we have to take it further than that and question these conceptualizations that we're coming up with in the first place. Go back to the diagnosis in the first place and look very closely at the validity of these diagnoses and of the effects of being diagnosed with something or diagnosing someone with something. That's, again, point very well taken. In one of your last chapters of the book, you talk about how the problem can become the problem. Is that related to what you're saying right now?
It is. Maybe it'll be worth just further deconstructing the idea of diagnosis, because this bit, I think, I've concluded after debating this with so many people from within my profession and from allied professions. So I think what I'm saying now is a statement that is as close as you can get to a statement of scientific truth. So for me, the issue about diagnosis is not an opinion. So let me just explain. We classify things in nature all the time. Language is a system of classification. We use classifications to help us orientate to what's going on around us, and to have various shorthands to communicate. But there are different types of systems of classification. So a system of classification by diagnosis implies a system of classification based on a proximal cause. In other words, an initial cause for whatever you're diagnosing. This is why, I don't know if you have this in America, but we certainly have it in the UK. If there's something wrong with your car and you can't figure it out, you'll take to the garage and they say they're going to run some diagnostics. In other words, they are going to do something to try and understand the initial cause of whatever that problem is. And we use that concept of diagnosis in other situations. So diagnosis is a system of classification based on proximal cause. Parts of medicine, it works really well. So if you have an accident and you've got a swelling in your leg and you can't wait there, and you go to the accident, or you call it the emergency room, and they carry out an X-ray and they see that there's been a fracture. So your diagnosis now that you have a fracture of your tibia or whatever, or fibula, or whichever bone it is telling you what the cause of, at least the initial cause of your, pain and swelling and the fact that you can't weight bear. And the treatment now is going to be specific to that cause. So in those acute situations, we see medicine working at its best. There's something which you can immediately hone in on, and you treat specifically, and the treatment addresses the cause. And there's lots of bits of medicine that are like that.
Mm-hmm.
And now you can build a technical bit of knowledge, because you can start classifying fractures. You can look at other things that might influence your likelihood to get a fracture. You can talk about different types of accidents causing different types of fractures. You can start building knowledge around specific treatments, different type of treatments, physiotherapies, etc., etc. So you can now build a body of knowledge that's based around a technical understanding of the nature of that particular condition. Things get a bit more complex.
Not to interrupt, but I was just going to add, I like the way that you put it too, when you were talking about the nature of this type of a phenomenon of a fractured tibia is a verifiable fact of nature. That to me it's a very important phrase, right? So, So please continue, but we're talking right now, this example is of a condition that is a verifiable fact of nature.
Exactly. It's indisputably beyond the imagination of the diagnoser.
Right.
The diagnoser is now discovering, not creating, the meaning of that pain and swelling and not being able to. They are in the process of discovering the reason for that.
Yes.
At least the initial reason. Of course, there may be other things that might be secondary. Some people might have cancers or osteoporosis or whatever, but things get a bit more complicated when you have chronic conditions that maybe don't show that easily. So diabetes is a good example, or maturity onset diabetes is a good example, because it might present with just a susceptibility to infections or just fatigue or some vague weight loss unexplained. So it can present in all sorts of ways. And you make the diagnosis of diabetes not by listing the experiences or the symptoms. So you do not diagnose diabetes by saying this is a condition of feeling thirsty, going to the toilet a lot, and fatigue, because several other conditions can present like that, and diabetes doesn't necessarily present like that. The definition of diabetes is your blood glucose is too high. It's again, it has an empirical anchor that exists beyond the imagination. And so the diagnosis is pointing to a specific cause. Now, there are all sorts of debates about where we should have the cutoff, about what types of treatments when, about what other things might be contributing to having high blood sugar in the first place, and diets, and all sorts of cultural things might come into that. But the diagnosis itself, and you can see that reflected in the definition, refers to some primary causal factor. Things get a bit more complicated when we're into neurological conditions, because now we're getting also meaning coming into it. But still, to some degree, neurologists try to find out specific things that they can find out. And there are still a lot of mysteries and areas of contention. But you still often have physical signs. So, for example, migraines, we can't pick migraines up on any, on any brain scans or ECGs or anything like that. But you do have some distinctive physical symptoms that often respond to certain treatments. But at the same time, it's well known that migraines can be triggered by psychological issues. Psychological issues can be involved. So we're getting into more fuzzy areas. But once we get into conditions that we are calling diagnosis in psychiatry, we clearly have lost that empirical anchor. It's kind of disappeared. So we're no longer talking about debates about the boundaries of, what's too high blood sugar and what's acceptable levels of blood sugar. Now, it is entirely subjective. The parameters are subjective. The things that are being reported are subjective. There's no physical signs. There's no test. There's nothing that can take you beyond your imagination as a diagnoser. So we are into a different, and as I've said before, you are also now in the in the situation, in the, if you like, the territory where you are now creating a scaffolding for how a person starts to understand their experiences. To help you understand that a bit further, if we were to practice medicine in the same way that we're practicing in psychiatry, you'd go to your doctor with a cough, and the doctor would ask you about the history of the cough, and they wouldn't listen to your chest. They wouldn't do an X-ray, wouldn't do a sputum sample or a peak flow meter. They'd diagnose you with a recurrent cough disorder. But, we know kind of implicitly when we go to the doctor or to the medical profession and we're looking for a diagnosis, we want to understand the cause. We want to know if the chest pain is a heart attack or is it acid reflux. We kind of implicitly know that diagnosis is a system of classification based on proximal cause. So when we start mistaking what we do in psychiatry, that what we're calling diagnoses that have been literally voted into existence by committees, that this is something that exists in a concrete way inside you, that we've diagnosed something going wrong, something abnormal, something you've not discovered what's going on, because I think between inputs from the environment and outputs in terms of our experiences and behaviors is just a big black box. We really have no mechanism. The only thing we can say with certainty about that bit in the middle is that it's a meaning making. It tries to make sense of things. And so we actually end up creating, by giving a diagnosis, we've created a certain scaffolding. And I think the scaffoldings we create when we do mental health diagnoses are potentially disempowering. I mean, I can understand the psychological appeal of it. It would be nice to think that you can go to somebody and he can tell you your suffering is the result of this condition or that condition. And now it will give you hope. Oh, something's been understood. And it will give you hope that now they'll know what to do about it. So even if the scientific thing isn't valid, and it's clearly not valid, you can understand why it would still be appealing for psychological reasons. And people would then think, oh, I'm not alone in this. There are other people who've got this condition. But for that to be something for us to say, okay, fair enough, the science is missing, but actually there is a real pragmatic role for working in this way, then we would really need to demonstrate that when we make diagnosis, and since we've been making diagnosis, we're making more and more diagnosis than we've ever done before, that we would really need to demonstrate is having some positive impact on people's lives. that their lives are improving as a result. The treatments are making a difference at some population level, some way of measuring that there is a positive difference. But the evidence is that in those countries that have got the most mental health services, some of the worst outcomes. In fact, seems to be almost a correlation. Not almost, there is a correlation, and no correlation is not necessarily causation. But seems to be a correlation that the more treatments we provide, the more people seem to end up long-term disabled and taking disability benefit. The higher the number of people who don't get back into work or into education, that the future outcomes of those who get caught in mental health systems is really quite poor. And it's not something that you see in other branches of medicine. So in some ways, it feels like a cruel trick to be playing on people, that we're not being honest with them, that when we give them a diagnosis, this is not a diagnosis. We're providing a way for you to think about your experiences. And so these are the types of questions that the more I understood about the lack of evidence and about the poor outcomes, these are the sorts of things that made me want to go deeper into understanding what is the potential implications of running a system that has such poor outcomes, that is not based on anything that appears to be advancing any scientific knowledge anytime soon, and yet we're acting as if the opposite is the case. What are the implications? Why is this? Why is it resulting in such poor outcomes? Why are we not making any progress with our scientific knowledge? And I guess my answer was that we've created a paradigm in starting with the belief that we know how to categorize people into something that has a scientific validity, a scientific starting point, that as long as we operate in that paradigm, this is what we should expect. We can't expect scientific knowledge to advance, and we can't expect clinical outcomes to improve. That basically has been my conclusion.
Thank you for deconstructing that. The nature of a psychiatric so-called diagnosis. I think that's just such an important thing to understand for people. And I want to read a couple more quotes. One thing you wrote: to clear up this abominable mess, we must first rid our trainings, services, and culture of the pseudoscience that has delivered the diabolical outcomes we have, where services are better at creating long-term patients being slowly poisoned with neurotoxins, erroneously labeled medication, than alleviating understandable distress. And as that's just one of those statements which is why I said in the beginning, this is one of the most scathing, harsh criticisms of psychiatry, but it is warranted, in my opinion. And then to pick up on more specifically the note, that we're on right now regarding diagnosis, I hear what you're saying, that it would be one thing to admit that these are not diagnoses in the same way that all other medical diagnoses are diagnoses. And it would be one thing to admit that, but then say, but it is helpful for a person to receive this way of thinking about their condition. But there's no evidence that that's helpful. And moreover, as you say, you recognize the deeper problem in all of this, I think it's a great way to put it, what you just said, that when a psychiatrist or psychologist makes a diagnosis, they are offering a way of thinking about that condition. But the individual receiving the diagnosis, that's not their framework. They're not thinking of it like that. Like, this person is offering me a way of thinking about what I'm experiencing, because the psychiatrist doesn't explain it like that. But that is what's happening. And the deeper problem with that way of thinking about the condition, as you wrote, is that I'm paraphrasing a little bit, but our language has been trapping us into a fear of and alienation from the richness and intensity of our emotional lives. And that is like you wrote, that the deeper problem in this paradigm. And I couldn't agree more. I think now, I also, I was thinking to myself, I usually don't play devil's advocate in any way, because I'm not, I'm such in alignment with my guests on this topic, but I do want to do a little bit of devil's advocacy for you, and just, so that people can hear what your response would be to someone who disagrees with you. So what would you say, to a person or a parent of a person or a spouse of a person who's, severely depressed, and they're almost lifeless, they can't function? What would you say for a person who's experiencing that, who might hear the quote that I just read off and be like, what do you mean the richness of my emotional life? I'm severely depressed. I can't even function. How can you say that? What would be your response to a comment like that?
Well, I'll take you one step back, if I may, because I think you hinted at the something that I argue in the book about a process that. So this is not a scientific position, but this is like clinical reflections. So this is now in the realms of opinion. One of the things that happens, because I'm a consultant child psychiatrist, so the sorts of young people, so I see young people under 18, and the sorts of young people that get referred to me tend to be the ones who've, either parents are looking for medication or looking for a diagnosis, but also I get a fair number of people who've been seen by other people in the team, often been seen by a number of others, and who sort of been in the services for maybe a year, maybe 2 years, and things don't seem to be getting better, or this is their second or third time. So there's sort of people who seem to get stuck. And I will come back to your severe presentation in a minute. I just want to take you through this process before getting to that. And one thing that I began to understand after a while is that however brilliant the therapy might have been, and some of them had also been prescribed medication, and things had improved and then not improved. However brilliant the intervention had been, if there wasn't a way of shifting this idea that there's something in there that's gone wrong, that's dysfunctional, the chances of making a more enduring recovery seem to be slimmer. And I began to understand a bit more because, I've been a consultant for a long time. I've had various management positions. I've done a lot of training, including training for young psychiatrists, trainee psychiatrists. So one thing that trainee psychiatrists recognize very much is that they this is in adults, they get to sit in and do clinics for patients who've been with the service a long time, and who just come, for year after year for their review appointments. You change their medication, and they're very familiar. I've had these chats with them, because it hasn't changed much from the days that I was doing adult psychiatry many years ago, is you'll find they've had several different diagnoses. They've probably been tried on each class of psychiatric drugs. They usually by several years, have 3 or 4 different medications that they're on. And, some of them are sort of functioning at, some sort of acceptable level, and other ones just keep coming in and out of hospital. So, and then as a child psychiatrist, you've got that chance to see how this process might be developing in its early stages. And one of the things that really struck me was that once people had the idea, and their parents and others, that there was something wrong, and I don't just mean like the idea that there's some sort of chemical imbalance. It doesn't even have to be as overt as that, just that there's something wrong in there. There's something wrong with me. One of the phrases I really hate at the moment is one of my pet hates, is this idea of emotional dysregulation. We've got all these words, all these pathological words to label people that they're reacting the way that they shouldn't be, that they're feeling the way they shouldn't be. They're responding in a way that's too extreme. They're being too angry. They're being too sad. They're being too hyperactive. They're being too shy. We have a myriad of ways of labeling these things. And I remember years ago, when a penny started to drop for me, and I'm trained in various psychotherapies as well. I'm not just a psychiatrist, but I used to do kind of more what I would think of as more formal psychotherapies, systemic therapy, psychodynamic, and so on. And so many years ago, this young woman who I was seeing for sessions, and I'd also seen her with her parents, and she'd been in services many, a lovely young lady. And one day we had that conversation about her feeling that she had this thing called depression, and that somebody had told her at some point it was treatment-resistant depression. And we started having conversation, and at the end of the conversation, I was trying to convince her, there's nothing wrong in you. You're reacting the way human beings are meant to react. A lot of shit has happened, excuse my language, a lot of shit has happened in your life. That's the way we're built. When bad things happen, we feel bad. And when bad things happen when we're kids, when we're young kids, we internalize that, because as young kids, we tend to be much more egocentric. So we tend to feel that somehow we've caused the bad things to happen. And when we grow up, we kind of internalize, we've got this horrible feeling that we're the cause, nothing ever, even if good things happen sooner or later, it's all going to go wrong. So you're just reacting as a human. There's nothing wrong. You've got a brilliant brain. And she recovered within a couple of days, within a couple more sessions.
Wow.
And she was ready to be discharged. And it's sort of, okay, so I didn't realize just how widespread this issue was about. Once you start to internalize this idea that there's something essentially wrong. So, and we're popularizing it in the way we think about mental health. I think one of the worst things we're doing at the moment is all this mental health awareness campaigns, because what do we mean? I do this, I do quite a lot of training, and I do this exercise with people I've not met before when I'm doing training. And I ask them, right, let's start with the basics. What is mental health? What is mental ill health? What does that look like? And people come up with interesting thoughts, but what they all have in common is that they all are talking about something subjective. They can't find any clear way of hooking. So it's so open to interpretation. Yes. So when we get so many people thinking oh, I've been feeling really bad for the last couple of weeks. And your parents are thinking that. And you're hearing all this thing about mental health awareness, and that maybe you need to see somebody and you need to intervene early, because if you don't intervene early, you're going to have more problems later in life. And it starts you on a journey of a kind of antagonism with a part of yourself that you might feel that you have to find a way to suppress, control, get rid of, and rather than how you might accommodate, understand, be able to accept, and I don't mean that in a flippant way, but be able to appreciate that none of us can actually escape suffering. Suffering is part of the human condition. It's the way we're built. So instead of doing that, you are in danger of inviting people into a potentially lifelong struggle with a part of themselves that they've come to experience as being, there's something fundamentally wrong with it, something fundamentally out of the ordinary with it. And this is where the whole cycle of the problem becomes the problem, starts to take root. You start carrying around an idea that this is something wrong. You can't deal with it. You need an expert to cure it. And if it keeps coming back, that means it's even more serious than you first thought. I often use with people the example of insomnia, because most people experience insomnia, and how usually the thing that first keeps you up at night is you're stressed, or you're worried about something, so you can't get to sleep. And then after a few nights of not sleeping, you start to think, well, is it going to happen again tonight? Am I not going to sleep well? How many hours have I got to get to sleep before I have to wake up and go to school or go to work or whatever? So as the process go on, eventually the cause of insomnia is insomnia.
Yes.
And you might then try various things, and if it improves your sleep for a few nights, you think hallelujah, and then a few nights later it's back again. So now you think you have to find something even more. So each time you try an intervention and it either doesn't work or only works for a while and it comes back again, it increases your sense of how difficult and oppressive this thing you're trying to get rid of is. So it sets up a relationship and a way of a certain meaning and a certain interpretation that you give to that problem. So that's why I call it the problem causes the problem. So whatever started it in the first place has maybe become less relevant now to the fact that you have the problem and that you keep looking for solutions. And what I understood was something that appears to be helpful for quite a few people that I see is to help them change their relationship with the problem. Instead of seeing it as something oppressive, instead of seeing that they can't get on with their life if they don't get rid of it, it's about how do you help people to find a way to not feel scared by this, because it's like, don't feel scared about your emotional life. And there's all sorts of different ways of and different metaphors that I can use, but the basic message is my basic starting point for everybody I see is that you're doing the best that you can. The things that you're experiencing are within the realms of the ordinary, that's the word I use, and or understandable. That you're reacting as a human being, and the way we're built to react. And also that I start with the assumption that most of us, that we're all, as well as being vulnerable, because I think that all the mental health propaganda is propagating a view of human beings as being, a bit like the equivalent of the original sin. We're all vulnerable until proven otherwise, sort of thing. But actually, I start with the view that people, stories of suffering are also stories of survival. People get through. They've got capacities. They've got abilities to bear. And actually, sometimes we learn more about the nature of life, the nature of our world, through our experiences of suffering, as opposed to trying to, there's countless accounts of people who've had their lives transformed. And it doesn't mean that the suffering was any less horrible or that it was something that they wished upon themselves. But we shouldn't just dismiss suffering as something that we just have to get rid of or eliminate. It's something part of being human. So with your person doesn't matter how severe things are, I'd really want to understand what is the model that they have and the model that the people around him or her have of what's going on. And that's kind of where I work these days. I'm trying to help people think about. So I think as practitioners, whether you're psychiatrists, psychotherapists, psychologists, we're all essentially philosophers. We're working with systems of meaning. And what we provide is, rather than us providing a system that gives you the correct meaning, we provide models with consequences. So we should always think about the models. We want to provide models. We want people to have ways of understanding and thinking about their experiences. But we should always think about, what is the consequences of this way of thinking about? And that does mean sometimes working in a diagnostic frame if there are certain things that I think actually the consequences of working in that frame, at least for part of it, might be beneficial to this particular young person whose parents have really lost their patience with them,
right?
As a way of. So my starting point is thinking, being aware that you are not going to be discovering the truth about what's going on. You're going to be offering a way of a framework for how you make sense about what's going on. So think about your model, not in terms of its truth, but in terms of the consequences of using that model.
Brilliant. That brings several different thoughts to my mind. Quickly, and just a comment on what you just said about how those of us in this field are essentially philosophers. I like that, and I agree with that. And I have thought about how, many of us, like I have a PhD in psychology, and most people know what PhD stands for. It stands for philosophy doctorate. I'm a doctor of the philosophy of psychology. Yeah. And that, I think, is the right way to describe it, and what's interesting to me is that a psychiatrist, unless they are, I'm not sure if it's, I don't know what the curriculum looks like for becoming a psychiatrist when you go to institutions in the UK like you did, but I know that for as much as I've looked into it in the US and talked to, US licensed psychiatrists, the curriculum in medical school, it makes sense to me that they don't end up being called PhDs in the field. They're medical doctors, right? So a psychiatrist is an MD. And to me, that lack of philosophical thinking is is evident, and the title, lacking the PhD in front of their doctorate, it's just appropriate, to be honest. So what I'm saying is, I think psychiatrists would benefit tremendously if they begin to think more philosophically. And it's very apparent to me that the curriculum in medical school, and as you become a psychiatrist, it really does not push people to think philosophically in this way, which makes me feel all the more respect for psychiatrists like you who choose to think philosophically about this. So that was one thought I had. The other thought I was having is, there's in social psychology, some people may be aware of what's called attribution theory, which is simply a way of understanding the way we think about each other and the way we think about ourselves. And so an attribution theory is basically saying, we're often trying to identify the causes of why people did what they did or why we do what we do. And so, in other words, we are attributing the cause of a behavior. We're attributing a behavior to a certain cause. And in attribution theory, there's something known as an internal attribution and an external attribution. And an internal attribution is when you say, basically, that person acted like that toward me because they are like that. My server was rude to me because they are a jerk. Or you can think about it in terms of yourself too, right? Like, I act the way I do because that's who I am. It's in me. So that's an internal attribution. And then an external attribution is when you attribute a person's behavior to causes that are external and impersonal, not internal and dispositional, but situational. And so that would be like, my server was rude to me because they must have been really busy. And situationally, and that must have caused them a lot of stress. So then there's what's called the fundamental attribution error, which is when you misattribute an individual's behavior to internal causes when it's actually due to external causes. So you thinking your server was rude to you because they're a jerk, but really they have rent due tomorrow and they don't have the money for it, and they have 5 tables all at once, and etc. And the thing about the difference between those two is it elicits a much different emotional response toward other people when you're making attributions of other people, right? Because the acknowledgement you're making basically when you make an external attribution is, if I was in that situation, I would also be acting like that too, right? And it's not personal to them. So it's, and basically the goal is to just kind of get that right. And when it comes, so that fundamental attribution error, when you are attributing a person's behavior to internal causes when they're actually due to external causes, the epitome of this is what we're talking about now, psychiatric diagnoses and the etiological assumptions about psychiatric so-called diagnoses. And to me, it's a crime against humanity to make a person who is living in an unjust society, who is understandably distressed and anxious and depressed due to societal, cultural factors, to make them think that it's something wrong with them, with their brain. In the US, there's about 50 million people in poverty in one of the richest countries in the world. That's so,
how can that be right?
How can that be right? And, many people are aware of the famous quote by the Indian philosopher Jiddu Krishnamurti, who said that it's no measure of health to be well adjusted to a profoundly sick society. And it's no measure, on the other hand, it's no measure of sickness or unhealth to be well adjusted or to be poorly adjusted to an unjust society. So I feel very strongly about this, because what you're saying about the way a person is understanding their own condition, it just matters so much. And there can be, right? And there can be a sense of shame that gets attached to all of the feelings, because now I think there's something wrong with me. It's my fault in some way. It's my fault for not getting better yet. And so Yeah, these are some of the thoughts that are coming to my mind. And the other thing I want to say really quick before I want to hear more of what you're thinking is I love your approach, and to acknowledge that suffering is inherent in life, and then we seem to be attempting to delineate between normal amounts of suffering and abnormal amounts of suffering. And over time, when you examine the DSM, that line separating normal from abnormal levels of suffering has moved so that now it includes more of what was once considered normal amounts of suffering. And you can the trajectory is that line is going to continue to move, to continue to include what was once thought of as normal amounts of suffering. And that's a huge problem, because that's this insidious trap that you are referring to. And it can cause people to identify as an individual who has this condition. It can cause them to believe and therefore expect. Their brain produces these, depressed and anxious mental states on a regular basis because they have this so-called chemical imbalance theory. So these internalized beliefs that we have are profoundly problematic and make matters much worse.
Yeah, there's very little we can do directly to change people's social circumstances and their histories. But one thing we can do is provide them with a framework that doesn't end up blaming something. The fault thing is an interesting one, because one of the attractions or apparent attractions of the idea of a psychiatric diagnosis is that it's not my fault.
Right.
That there's something, and it's a strange one, because in many ways you can't escape an idea then that somehow you are the cause of your suffering. That it's kind of even worse than the idea that it's your fault, because if it's your fault, maybe there's something you can do to rectify it if you still have some idea that you have some capacity. But I think the main thing that we can provide to people is an opportunity to think of what they're experiencing in a more human way, rather than something to be feared. That there's sort of some monster trapped inside them that they're constantly having to be in a battle against, to try and control. It might not make your life any better to understand that not being able to pay the rent and your children's school ringing every other day about is you're maybe not going to be able to change that, but at least for them to understand, well, God, if I was in your shoes, I'm not sure how I would deal with that, and to help them to view it in a more human, as opposed to there's something deeply wrong with me way. And to have a bit more, because I think as a culture, there's something paradoxical that happens. We tend to promote the idea that we've become a very tolerant culture. But actually, the more we've created human typologies, I think it's a reflection of how intolerant we are, and how narrow our idea of what the ideal human being should be like. Similarly, we've got this idea that we're very hot on child protection and making sure children have a good start in their life and so on. And yet we've got a generation that's been pathologized more than any other generation. So we've got all of these paradoxes that speak to a culture that is really quite intolerant of the nature of human experiences and the diversity of human experiences, wanting to pigeonhole. But I think it even goes worse than that, because in its cultural life, what I've understood is diagnoses now operate as brands. And this is why the popular brands continue to expand, because they are very subjective. Most of us can identify with many things that get described in a diagnosis. I kind of think of it almost like reading your astrology stars. It's such a vague thing. So once it gets into the marketplace, it's not just medication, but experts, books, courses, institutes, research, a whole set of things, products starts to grow up around popular brands. The popular brands are behavioral problems in kids and emotional and anxiety problems as they get. These are the big brands. So you find certain diagnostic categories attract more and more. So they just become big money-making machines, and that pushes the expansion of these concepts out into all corners. And so we're seem to be where we've been on a journey of alienating ourselves from the ordinariness of our emotional lives and our behavioral difference. And I don't think, I think there's plenty of evidence, one, that scientifically this is not going to hold. You mentioned that right at the beginning, and of course, the classical writing on that is Thomas Kuhn, who used the social language of revolutions, because what we call science is done by scientists, it's done by people. People have cling to certain ideas, and they have their own cognitive dissonance to deal with. And so I think he correctly used the term scientific revolutions happen when a paradigm shift happens. And that's why I don't think that there is too much that doesn't work with the current diagnostic paradigm. It is not open to reform. If you just try and reform it, you're not going to be able to affect how we might improve our knowledge or how we might improve our clinical outcomes. I think we've got so much evidence that that's the case. The scientific evidence means that our system of diagnosis is unsustainable. That's why it has to be more than reform. It has to be some paradigm shift. And we do have other models out there, plenty of other models actually, that that are, if you like, on the shelf and ready to go, from power threat meaning framework to open dialogue to narrative approaches to feedback-based models. There's a good few out there. So
yes,
it's not that we would have to invent something from scratch,
right?
But we would have to move beyond a diagnostic-based model. And that's not the same as saying that that we are not going to that this is about not recognizing people's distress. Quite the opposite. It's about recognizing that this is what it means to be human, and it's about providing support that actually confirms, builds on that, and helps people discover their own capacity and their own empowerment, even if it doesn't improve their social situation, at least it might give them, might make them a little less hard on themselves.
Would you go as far to say that there's no use for the DSM?
I think the DSM and the ICD in mental health simply need to be, ceremonially burnt. We'd have to get rid of it, and we'd have to educate the public that, we've had, I don't know how much it reached the US, but in the UK, it did get into the news about the recent meta-analysis of the chemical serotonin in depression. So, you do get things from time to time, but these sorts of things, we'd need a lot more publicity to help people understand that this story, that we have diagnoses, that we know what we're talking about, that we know how to make them, and that we have treatments that are very specific, and that these treatments have good long-term outcomes. These are all the stories that need to start being deconstructed.
Yes.
So that would need to go alongside, a thoroughgoing revolution in mental health services.
When I think about how would this revolution occur, or it's, perhaps you could say that that it's underway, but how will it really gain momentum and reach a critical mass? I'm an educator, and I'm very proud to say I'm very, very happy, I guess, with the decisions I made as my younger self that led me not to becoming a clinical psychologist or a psychiatrist, but a psychologist who is an educator and a researcher and who thinks philosophically about all of this, and who is willing to provide what I frame as consultations with people who are struggling. But I just think, I don't know, again, when I think about how will this revolution gain momentum, I really think education of the masses is a critical ingredient. And I see it happen. I teach in the college setting. And so I see, large groups of students, many like consistently, right? And we get into this. And students who take my psychology courses end up with a decent level of education on the context around all of this, including the barbaric history of treatments in psychiatry, and then just all of the philosophical underpinnings behind the current paradigm, which are so questionable. And once you expose them, again, I witness it in real time, the way students' minds change around this topic, and the way that they're, feel better able to critically analyze it for themselves going forward. So I think that's going to be an important part of the revolution, is just education. And then, like you said, publicity, whenever things are exposed, like the lack of basis for the serotonin hypothesis and things like that. Or for example, just to publicize something else, there are many ongoing legal cases in the United States of foster children being drugged just in a way that just irks your soul. It's so incredibly unjust, because it's so obvious that they are being given drugs just to manage their behavior, to make it easier on the adults who are having to supervise them. And when you look closely at the foster care system, and much credit to the amazing people who make it good in many ways, but there's all kinds of ways that if you were a child going through that, you would be very anxious or depressed. That would be a totally normal response to being completely insecure about where you're going to live, who you're going to live with, whether you're ever going to have a family. So that's a norm, depression, anxiety, these are normal responses to a situation like that. So anyway, there's a poem that I love by Rumi that I think of often when I was thinking of it often when I was reading your book, and all the ways that you talk about the importance of changing your relationship to the problem, changing the way you view it in the first place, changing your relationship to your emotions so that they don't seem like scary monsters or that there are signs that something's wrong with you. And I'll recite the poem. I got it off the top of my head. It's called The Guest
Go for it.
House. So for the listeners, the poem is by Rumi. It's called The Guest House, and it goes, "This being human is a guest house. Every morning there's a new arrival, a joy, a meanness, a depression. Some momentary feeling comes as an unexpected visitor. Welcome and entertain them all, even if they are a crowd of sorrows who violently sweep your house empty of its furniture. Still, treat each guest honorably. They may be clearing you for some new delight. The dark thought, the shame, the malice, meet them at the door laughing and invite them in. Be grateful for whatever comes, for each has been sent as a guide from beyond."
That's lovely.
Isn't it lovely?
That is.
And I just think it's a great metaphor for how to deal with emotions.
Make a great therapist.
Thank you. Yeah, I people love the poem, like that's one of those poems I like to share with my students, and it always hits hard. I also work in a jail, but I love what I do in the jail setting because it's not under the framework of I'm a therapist and there's something wrong with you, so you have to go see a therapist. Instead, it's an educational course. It's a personal development course that inmates can choose to take. And what's interesting, I find, is that whenever I've shared that poem in there, it hits especially hard, and people are especially like if affected and empowered by it. And again, it offers a whole new way of viewing the darkness, the shame, the malice, the depression, that I think is much more productive, much healthier.
Provides a meaning framework.
Provides a meaning framework.
Yeah, I like it.
Yeah. And what I think is so interesting too about, the way that you were writing about the meaning making systems, it just kind of was eye-opening in different ways for me, especially to think about how many layers there are to the meaning making systems, and how the whole, like you said, you literally can't escape subjectivity in all of this, in the diagnosing that happens in the first place, because they were conceived of in the first place by people who are influenced by their own cultural meaning making systems. And then there's broad cultures, and then there's subcultures, and then it's like every layer closer to the individual, there are meaning making systems. And yeah, it explains the inescapable subjective nature of all of this.
Might as well face that reality if you're going to work in this area.
Right.
Yeah.
And it doesn't, and that's, I feel like it doesn't.
See, I think in one of the dangers of diagnosis for people who are practicing in this area is that I can understand why practitioners like it, particularly psychiatrists. I know a lot of psychiatrists, obviously. Is it gives you a sense of, meeting otherness is always anxiety provoking, especially if it's meeting people in distress. And so it helps you with your own defenses to feel that actually I can put that aside because I'm doing something technical here. So I'm listening to your story, but actually what I'm trying to do is find out what symptoms, what the form is, how you're talking to me. Is your rhythm too? I'm more interested in the form than the content. Okay, now I can put this together and make a diagnosis, and now I can explain to you the diagnosis and give you this treatment. And so that's very reassuring for you as a practitioner, but also it creates a you're not just constructing a meaning-making system, but it kind of creates a barrier of for empathy, because you're trying to, if you like, instead of trying to be close to that experience, you're using a system that helps you stay at some safe distance from the anxiety-provoking nature of meeting somebody else's suffering.
Interesting point. Wow. So I want to make sure that that a person listening to this conversation, let's say, who is suffering, that this ends up being helpful, because, it is crucial to understand the lack of like construct validity, as we might call it, in all of these diagnoses, and the problems that a diagnosis can bring about. But let's say, if we were to refrain from categorizing an individual's suffering in terms of DSM classifications, but if we were to acknowledge this person is suffering intensely with tremendous anxiety and or depression, etc. You talk about, your approach. So I'd like to read what you wrote were the 5 principles that guide your practice, and I would love to hear you expound upon them. Number 1 is deconstructing the diagnosis. Number 2, understanding the relevance of psychological injury, which is a phrase you like, in place of trauma, which is a term that's, I agree, has become popularized. And yeah, it's just the waters are a little muddy around what trauma really is in this case. So yeah, understanding the relevance of psychological injury, working on therapeutic relationships, awareness of culture and context, and then awareness of the way that the problem can become the problem, and that once a problem is established, sometimes it perpetuates itself, like your insomnia example that you were mentioning earlier. So you wrote those as like the 5 kind of bullet point principles that guide your practice. And I would just love to hear more about just the way you practice, the way, your perceptual set around working with people.
Yeah, I think, like I said earlier, I always start from the principle that people are trying to do the best that they can in the situation they found themselves in. So I always start from the position of being non-judgmental, and and I think of they're experiencing as being part of what I consider to be ordinary and or understandable human experiences. In terms of the literature, the only thing that I think we can say with any certainty is that there is a strong association between adverse experiences of a variety of types and the likelihood of having a psychiatric or psychological presentation. It's not a one-to-one, but it just increases, and particularly if it happens when you're younger. And I prefer the word psychological injury because what hurts somebody can be very different depending on your history, your cultural background, than what hurts somebody else. And I also kind of found the idea of trauma quite difficult to talk in those terms, because I think young people who've grown up with things that have been unpleasant, difficult, they often don't think of it in terms of trauma. That might be a word we put on it because it was their normal. They didn't have anything else to. So that's one of the reasons or some of the reasons I tend to talk in terms of psychological injury. It's just the idea that you've been hurt, that was painful, that was unpleasant, that was difficult. And I can understand why you might be reacting this way all these years later. You still expect things to be, you're trying to protect yourself from things being hurt again, whatever. And also with parents, one of the things that because a lot of my work involves working with the family system. I think people have a context. So I think of the context as their support network. They can often do a lot more than they believe they can do. Parents may come expecting that we have the answer and the specific intervention. But actually, that's quite disempowering. So a lot of the time it's trying to help parents see how important they are and how much they can influence, and maybe just also to be a bit more patient sometimes about what they expect or when they expect it, or there's all sorts of things. So I see that kind of system that people are part of as a strength, as a resource, as something to build on with them. And also they can be really important in helping to demedicalize or depathologize the story that so you can talk to the young person, but if you talk to the young person and their parents, help them understand, for example, that the voices that the young person is hearing is not the main problem. The main problem is your interpretation of the voices and the fact that you want them to go away. And if they don't go away, that makes you feel even more hopeless. But what if the aim of our therapeutic intervention is not about how they go away, but how you engage with them, how you understand them, how you live with them, what they can teach you, and parents often get that. So working with parents is, and we're very, we don't do culture well at all. We don't recognize, for example, that what we call psychiatry and psychology is the product of a culture in itself. It is a particular way of thinking about the nature of human functioning. My background is that my father's Iraqi and my mother's English, so I speak Arabic. And I've had these discussions with my father when I'd written a number of papers for the Arab Journal of Psychiatry, and we had to translate the abstract. You can write it in Arabic or you can write it in English as long as you have an abstract in the other language. But I fell down on the first article that I did, almost the first word, because there actually isn't an equivalent word for mental in Arabic. There's a choice of 3 different words. And their roots are interesting. For example, the word we settled on is a word called nefsiya, and it kind of refers to a kind of soul. So talk about amrad nefsiya. It's like illnesses of the soul. And even the word nefsiya is interesting because its root is in the word tanafus. Tanafus is breathing. So there's already a connection between breath and the idea of soul and the idea of mental functioning. So, and there's many other examples like that you can see that the language holds clues as to how culturally you construct our idea of what subjective life is. differently, and we seem to have very little awareness of the different ways we can construct our sense of mental functioning, our understanding of relationships, and our understanding of our relationship to the broader world. I have to finish, I'm afraid, Nick. But I'm loving this conversation.
I know, I am too. And that was a fascinating last piece there too. Thank you for sharing that. Well, let's wrap this up. And I just think your voice is one of the most important voices in this whole conversation. And I am so grateful that you speak out, boldly, fearlessly, honestly, thoroughly, and that you're able to continue to practice as a psychiatrist in a way that is genuinely helpful to people. So, Dr. Timimi, thank you for your time, and thank you for who you are and what you do. Much appreciated.
Well, thank you so much, Nick, for inviting me, and thank you for all the work that you're doing. We need to keep publicizing this.
Yes. Yeah. Well, let's stay connected. I'll reach out to you again soon, and I'll let you know when this conversation is made public. But yeah, for now, have a wonderful night, and hopefully I'll talk to you again.
Let's hope so. Take care.
You too.